Surgeons want two answers from a perianal MRI. What is the relationship between the fistula and the sphincter, and are there any extensions that will recur? That is it. Most reports do not lead with that. The new How I Do It paper is trying to fix it. Same two authors, 20 years apart. In 2006, they wrote The State of the Art. It surveyed the field and set out the approach. Now, same journal, same authors, a How I Do It. The technique is settled. The focus has moved to the report and to assessing response after treatment. I think this is the cleanest What Changed episode we have done. Anatomy first in 30 seconds. The sphincter is 4 to 5 centimeters from inside out. Mucosa, internal sphincter, the intersphincteric space with its longitudinal layer, then the striated muscle, external sphincter in the lower half, puborectalis in the upper half. The dentate line sits roughly mid-canal. You will not see it directly, but you can estimate it, and coronal helps. About 12 anal glands sit around it. Their infection is where most cryptoglandular fistulas start. The Parkes classification still holds: intersphincteric, transsphincteric, suprasphincteric, extrasphincteric. The first three start as intersphincteric infection, the fourth comes from higher up. If you see extrasphincteric, look at the rectum. Now the protocol: 3 planes aligned to the anal canal axis, not the body axis, planned from the sagittal scout. Coronal parallel to the canal, axial orthogonal to it. This is the single most common technical error on outside studies. If the obliques drift, the whole classification drifts. 3 sequences: T2 without fat sat for anatomy, the sphincter layers, and fibrous fistula walls. T2 with fat sat or stir for active tracts, abscesses, and extensions. And IV contrast with FATSAT T1, which is optional. It separates granulation tissue from true fluid in Crohn's and confirms healing, but it is not routine and there is no consensus. 2 things the paper tells you not to do. Do not use diffusion. It lacks the spatial resolution for subtle findings, including healed tracts. And do not rely on an enterography protocol if the question is a fistula. It is inadequate for the sphincter. A dedicated pelvic series is mandatory. 1.5 or 3 Tesla both work. No proven benefit from 3. No bowel prep needed. Coverage matters more than you think. The sagittal must reach both pelvic sidewalls. The axial obliques must include the full sphincter, the anorectal junction, and a few sections above. Cover only the sphincter and you will miss supralevator disease. Extend the field of view live if the disease looks more extensive than the request suggested. Now the report. The 2 questions the authors call out in both papers. First, what is the relationship between the fistula and the sphincter? Can it be laid open without making the patient incontinent? Second, are there any extensions that will cause recurrence, and where? That is the report. Everything else is supporting evidence. A quick word on the internal opening. Give a clock position. Most are at 6 o'clock posterior, and give a level. Pick one convention and stick to it. And if you cannot trace the tract to the mucosa, do not invent a location. Most internal openings are narrow and never widely patent. Report the most likely opening as the site of maximal intersphincteric infection. That is what the surgeon checks first. The paper anchors its reporting in the ESGAR minimum dataset. There is one line that should hang above every perianal MRI workstation. It is unhelpful to describe the many twists and turns of each individual fistula, because that is not how colorectal surgeons think about the disease. Radiologists must use language that surgeons understand. The minimum dataset is 6 items: the clinical question, the fistula with its location, Parkes class and openings, any extensions with location and maximal diameter, sphincter integrity, associated findings, and comparison with prior imaging. 6 items, that is the entire ask. Most reports either skip 3 of them or bury them after 2 paragraphs of prose. Response and healing is the biggest practical addition since 2006. For research and trials, there is the Magnifi-CD score. 6 features: contrast required, externally validated, near perfect agreement between readers. It is accurate but too time-consuming for daily work. For daily practice, use the top-class consensus. Response is increased fibrosis, a clear reduction in tract diameter, length, or abscess size, and loss of the bright T2 signal. A healed fistula is a fully fibrotic tract with no bright FATSAT T2 signal and no enhancement if you gave contrast. Re-image somewhere around 3 to 6 months after treatment starts. Apply these criteria strictly. Subtle residual abnormality predicts recurrence. The paper shows a case where a faint curvilinear hyperintensity was missed on a complete healing read, and the patient recurred a year later. Two mimics worth knowing. Pilonidal sinus is midline, posterior, and subcutaneous. It rarely involves the intersphincteric plane or has an internal opening, and that is the diagnostic key. Hidradenitis suppurativa is extensive and superficial, affects the apocrine glands and spares the sphincter. It can coexist with Crohn's, which complicates the read. Malignant transformation is rare, but missing it is severe. Suspected with substantial deterioration after many years. Mucoid or blood-stained discharge, a new mass-like lobulation, or a budding appearance, which has been proposed as an early sign of cancer in a chronic fistula. Most cases will not look like cancer. The ones that do, look again and think Crohn's, even without a diagnosis. When you see extrasphincteric disease, a watering cananus, multiple extensions, or skin involvement, the surgeon may not have called it yet. Suggest it. So 3 things for the next perianal MRI: get the obliques right, or the rest is wrong. Answer the 2 surgical questions first and lead the report with them, and apply the top class healing criteria strictly, because subtle residual abnormality predicts recurrence. 20 years between these 2 papers. The technique conversation is over. The report is the new frontier. Both papers are linked below with the full breakdown and figures on Substack. Next episode is EP06. I'm Melina Pektasidis, and this is Rad Brief.